So I'd like to share screen again. Sorry about that. So let's get through to the correct slide. So in bipodal surgery, on the other hand, as we can dock at the various different places, as we can highlight through this talk, there's a mobility in the device, and we are not so limited by the anatomy of the spinous process, as we are actually sublaminar and below the spinous in the visualization. In terms of the scope as well as the working channel are independent of each other, which is beneficial in revision surgery when there is a lot of tight structures around the endoscope. So the key factors in adjacent segment degeneration revision surgery in particular is to design and decide whether we do an interlaminar approach or a far lateral approach. In the interlaminar approach or far lateral approach, main decision making is whether there is a proximal extent of laminectomy in previous surgery. If the proximal lamina is preserved, I think interlaminar approach is preferred. If the previous surgeries have complete laminectomy and there's no more caudal lamina of the decompressed segment, the dural tear rate is high, and then maybe a bilateral far lateral approach is recommended. In the distal junction adjacent segment degeneration, the distal extent of laminectomy is often not an issue because the is often preserved for the proximal lamina of the distal level. So just to highlight, we look at the bony bridge. If it's present in the distal junction, then we can do the interlaminar approach for proximal ASD. And if the bone bridge is absent, then we can consider a far lateral approach. And certainly if the predominant lesion is a foraminal lesion, then we do a far lateral approach. Just to highlight it with some example, this patient has a L3 to S1 fusion. And if you look in detail in MRI and CT scan, you can see that the proximal L3-4, the L4 laminar proximal region is still present. So the L3-4 decompression can be performed using UBE interlaminar approach, and we suspect that there will be a less problem of dural adhesion. However, in the right side picture, you can see the full open laminectomy with no more preservation of the L4 lamina, complete decompression. In these cases, if we do interlaminar approach, there's a higher rate of dural tear. Not that it cannot be done, but there is a higher chance of a dural tear. So there's a very important decision of whether you should do a far lateral approach, or you can do it bilaterally and still decompress the central region, or interlaminar approach, depending on whether the bone bridge is present. Some of the surgical difficulties is limited in surgical field in a revision setting, significant adhesion due to the previous scarring of the surgery, especially in open surgery. And then the tissue, because of the limited surgical field and adhesion, are less pliable and difficult to retract, which also leads to a higher chance of a dural tear and nerve root injury. As you can see from the picture on the top left-hand corner, dura tends to be a little bit more posterior, as you can see, and it can be extending beyond the laminar space. So we have to be careful because of that may lead to dural tear rate. Most of the complication rate in open surgery is about 34% is due to dural tear. And of course, because of that and other reasons, the satisfaction rate is lower in the revision setting. So we have to overcome the barriers. We try to dock on the laminar outside and to prevent dural tear straight away. We need to understand the depth of working space so that we get into the correct layer without injuring the dura. We need to decide how much resection is required, and there are certain anatomical landmarks that can guide us on that. And if the future progression, we need to advise the patient on potential revision surgery due to instability. And we may consider the early inflammatory period for early recurrence. There's some advantage of UBE, which I think must be highlighted by many of the experts. I think you can get a more magnification, get better in scar handling, and also especially in possible future scenario as we preserve more bone, and it can be easier to revise a UBE surgery. So my advice is to dock at the lamina instead of the interlaminar space or spinal laminar junction. We detach the superficial scar. We do the adhesiolysis by detachment of 3 points. I find that these 3 points are important. Capsular laminar, facet, pedicle. Then we can access to the deepest point through the pedicle. And the pedicle leads us to the vertebral body of the caudal lamina and traversing nerve roots. So first we have the dock. I think we dock a bit more lateral instead of a spinal laminar junction. We dock at the lamina. We do a adequate laminotomy, more lateral than the previous surgery. And then we identify the base of superior articular process, and also which will lead us to the pedicle, which should decompress sufficiently distally to visualize pedicle and follow the pedicle down all the way to this space. And then we know where's the deepest part of the space. As you can see from here, in the revision, first of all, you can see that there's a lot of scarring, it's less pliable. So you can see that you can't really push the soft tissue more easily medially. But we can more or less identify the base of superior articular process. This patient had a previous laminectomy. So you can see that the base of superior articular process is visualized. Sometimes you can use a shaver if there's excessive amount of scar that you want to clear for surgical view. I use a plastic cannula as such, so that we can retract some of this adherent scar tissue. And then we can assess the base of spinous process. If we are not careful, as you can see that the dura is now, in this patient, is more basically dorsal to the lamina compared to contralateral side. If we are not careful, we scratch it, we can cause a dura tear. In this case, we need to use a Teclosil and gel foam to repair the dura tear even before when we finish the surgery. So it's not very pleasant when you start the surgery with a dura tear, so you have to be careful. So after you did the adhesiolysis, and then we can now detach the starting from the middle point where the base of spinous process is. Then we gradually do detachment of the scar to the proximal junction and then the distal lamina. Once we identify that, we can do that trimming either by using a shaver or using the radio frequency probe. I find that the radio frequency probe is very useful as well. And then we detach the base of superior articular process and follow the pedicle all the way to the nerve root and the disc. So these are the ways that we can get to the deepest part of the spine. Once we know the deepest part of the spine, then decompression can be easy. So case 1 is a patient that has a proximal junction preserved, L3 to S1 fusion done 10 years ago with adjacent segment degeneration, as you can see here. The patient has fused nicely. This patient is 77 years old. The decision is made to decompress rather than do a revision fusion. My steps are written by a book that a couple of chapters I contributed to Javier's book. And this is the waterproof drape, and this is the setting that we use. I find that the bones radiofrequency and plasma coagulator is very useful in our surgery. And this is how it's done. You can see that we dock a bit more lateral in this case. We find the midline, and then we dock. You can see that it's a bit more lateral. I don't dock at the spinal laminar junction. I only dock at the lamina. And you can see that we first identify. Essentially, if the patient has the proximal part of the L4 is preserved, then it's like a primary surgery. So you can see that I'm using a cutting burr because Essentially, if the proximal junction is preserved, proximal lamina of L4 is preserved, then it's a primary surgery. So there's no difference in terms of how you manage the decompression. You can see there's very little scar in even a so-called revision surgery, although she had an open laminectomy fusion, so the scar in the skin and subcutaneous tissue is significant. But in UBE, because we talk directly on the bone, as long as the lamina of the distal junction, as you can see here, is preserved, then you can just do it like a primary surgery. So for the concern of time, I just speed up, and then we do a laminectomy. It's an L3-4, so we try to preserve that of the facet joint. And then we decompress the contralateral superior articular process in this setting. Fully decompress the spine. Try to preserve the contralateral SAP, especially important in revision setting because already they have more stress in the distal junction being more stiff. So there's a higher chance of further breakdown and revision fusion in the future. So this post-op patient did very well. Interestingly, we managed to incorporate the UBE scar back to where her laminectomy is. So she doesn't have any new scar actually. So the second one is a patient that the proximal junction is not preserved. And in this patient, we still decided to do the interlaminar approach. And I mean, it's expected that there's higher rate of dural tear, and he had that. So patient have a claudication, 2 bar stop, and some numbness in the over L4-5. He had a very interesting fusion technique, which using sublaminar wire. You can see that the distal junction is actually not preserved. It's impeded by the sublaminar wire. This is a very old fusion, more than 30 years ago. It feels well. However, the wire is getting into the lamina of the L4 junction. So you can see that the distal junction is no longer preserved. So we will be expecting a higher rate of dural tear. Nevertheless, we decided this patient required interlaminar approach. We did that, and this is the video. He had a dural tear, and very interesting. You can see the metallosis from the previous sublaminar wiring from the construct 30 years ago. I think we can still use the cutting burr in the proximal junction, but however, use more of the diamond burr in the distal area. So the decompression is still okay. I think a lot of time there's not much scarring despite open surgery. However, in the distal area, you can see there's a lot of scarring, and in fact, it's so adherent that I have to leave some of the flavum as an island to prevent further dural tear. You can see that there's a metallosis in the even in the region of the lateral recess. As we decompress, we found that there's a dural tear right over there as we take a couple of bites at the lateral recess. Use the Tacocil patch technique to repair the dural tear. And there's a lot of metallosis. In the end, we decompressed it sufficiently, and the patient did well. But you can see that I left some of the scar together with the dural adhesion. And then I used the tissue glue to help this patient. So the patient did well, didn't have much of a problem. I rested him for 1 more day in the ward. He was discharged in post-op day 2 instead of post-op day 1. I didn't use the drain in the patient with dural tear. So third case, adjacent segment, again, degeneration. I used a far lateral approach because the patient had previous laminectomy as well. For the concern of time, I just showcased the technique. I think it's L4-5. Previous did the L4-5 laminectomy, sufficient interlaminar decompression, but still have a far lateral compression for foraminal stenosis. So we plan a far lateral approach in this case. And you can see that we dock at the facet joint of left L4-5. So In the patient where the previous laminectomy fusion, the far lateral approach is good. I think a lot of times there's not much of a scarring in the far lateral region. It's controversial whether if you do bilateral far lateral approach, whether there is a sufficient stability if we do it significant central decompression. But in some of the elderly patients who do not want to have further fusion surgery, that's an option. So we identify the superior articular process, and then we take up the tip of superior articular process. And then we get progressively more medial. I tend to not expose the exiting nerve root entirely in the early stages of surgery. I keep the flavum and exiting nerve root around the exiting nerve root intact first. I go look for the traversing nerve root before I proceed on to expose the exiting nerve root, like in this case. So now I've exposed the traversing nerve root, so I slowly decompress the exiting nerve root from inside out. I think going from the inside out technique is good. After it's a floating technique, you could get inside, identify the traversing nerve root, find the axillar region, then from there on decide how far lateral that you need to decompress. So you can see that there's some extraforaminal disc, shrink it, and then remove the disc, open with the Indian knife, and then perform a discectomy. And finally, I like this hook RF that's provided by Bones. I think it can assess deeper. It has a natural curve to it, so it's quite good. Patient did well, and discharge post-op day 1. So from these lessons of periscope in war, we try to hit the target without collateral damages. I think adjacent segment is segment degeneration is common. Fusion is not always necessary. Choose a method that avoids getting direct complications. I think we try not to get a dura tear before we even start doing decompression. It's really depressing. So we try to hit the target and acceptable to the patients. Using with a clear visualization of lens, proper docking of the scope, good water pressure, which can help us separate the very deep scar tissue, and with tools in the separate portal and the correct weapon and scope. Sometimes we have to use 30-degree scope in the far lateral approach as well. You can minimize collateral damage and eliminate the target. I would like to use this opportunity to call for make advertisement for people who are having endoscopic papers. We are inviting and having this special issue in medicine. You can email me for more details. Thank you very much.
Perfect. Congratulations, Dr. Wu. Very nice talk.